Okay, so this is a 31-year-old male. He was. Can you scroll down a little bit? Sorry. He was diagnosed with hepatitis C. He has a history of IV drug use for 10 years and shared paraphernalia. I'm sorry, intranasal drug use. He started IV drugs for 6 years and shared paraphernalia. He's been clean for 2 years. He did attend drug rehab. He's not currently attending any meetings. His hepatitis A and pneumo vaccines have been started. His exam was overall normal. His ultrasound showed moderate diffuse fatty liver disease, and his elastography was F2. His labs, he has a history of hyperlipidemia, hypertension, vitamin D deficiency, opioid dependency, and he has bilateral lower extremity venous insufficiency with lymphedema. This is new. He's currently being worked up, but there was no clots or anything found. They think it's from weight and history. He's currently taking aspirin, buprenorphine, hydrochlorothiazide, metoprolol, and vitamin D. He is immune to Hep B. He is 73 inches tall. His weight is 335 pounds. His BMI is 44.2. Overall, his labs weren't too bad. His glucose was 114. His ALT was 103. AST was 58. His APRI was 1.0. His child was 5A. MELD score was 6. His iron was okay. The fibrosis biomarker was F1 to F2. He's HIV negative. Genotype is 1A. His viral load is over 12 million. And there's his hepatitis B screening. I don't think there's any drug interactions. So what would be the best option? I'm sorry, I jumped around there.
No, you're completely fine. Thank you so much, Gary. Does anybody have any following up questions?
Hey, Gary, this is Kaylee. Do you know anything about his alcohol use?
1 second. Let me double check my paper. He said he stopped drinking 2 years ago. He's still smoking, but he's not doing anything else.
Gotcha. Okay.
Any other questions before you go into recommendations? All right, feel free to unmute, raise hand, or speak.
I'll start. So I agree with you. I don't think he's got any drug interaction. So it's really a toss-up as to whether he's on, he's Medicaid insured. So whether he's on Mavorette or Epclusa, I think the real issue with this guy is his morbid obesity. His clearly has non-alcoholic fatty liver disease, and he's already got a little bit of fibrosis, and I would be concerned that he's developing NASH, non-alcoholic steatohepatitis, which, together with his hepatitis C makes his liver situation even worse. So, if you think about both his liver health and his overall health, he'd be a great candidate for bariatric surgery. I think at 335 pounds, expecting that he'll lose 10 to 20, at least 10% of his total body weight to make, to leach the fat out of his liver is probably not very realistic. And, he would probably, if he had bariatric surgery, would no doubt, or not, I shouldn't say no doubt, would be highly likely to lose 10 to 20% of his body weight. So I'd be thinking about it from that point. Also, he's got a history of hyperlipidemia, but he's not on a statin. Sounds like it would be useful, in which case Mavorette would be, not the optimal choice. And you would, need to, for both Mavyret and Epclusa, you have to think about, the maximum dose of a statin. It's typically like rosuvastatin, 10 milligrams or so. And, it might be better to have him be on Epclusa to, minimize any problems that way. But as I said, I would be more concerned about his hyperlipidemia and the fat in his liver. I think he'll do fine with DAA therapy. And you just have to consider whether, if you put him on a statin, then what choice you make depending on that.
Okay. Thank you.
You're welcome. I don't know, John or Kaylee, you have anything to add?
Not to add, I just agree with what you said. It's perfect. Just one other comment on the weight loss issue. I've had a lot of luck with our medical weight loss clinics these days now that Ozempic and similar drugs are available. I've really seen 30, 40, 50 pounds come off people successfully in those that are squeamish to get a bypass. Because obviously I don't think he's had Hep C long enough to cause that fibrosis. Probably not. And he's got a dual hit going on with the obesity and the Hep C. You can take care of the Hep C. One last comment is his APRI is 1, but his elastography and his fibro biomarkers are low. So I do not think this is a guy you'll need to do HCC screening on long term. His APRI is falsely elevated because his liver enzymes look like crap. Yeah, but once you treat his Hep C, they'll normalize, and then his APRI will be normal, probably 0.5 or something like that or less. So, but great job, Gary. You always present good patients, and this is a guy I think you can do a lot of good by to get him at least get that one hit out of his life with the Hep C.
Great job. Thank you so much. Do you have any other questions, Gary?
No, I'm good. Thank you.
Of course. Thank you so much for submitting that case. Hi, Julian. All right. Dr. Feinberg, did you want me to share my screen with your slides?
I can do it.
Okay, let me make you a co-host. Give me one moment, please. All right, you are able.
Okay, can you see that?
Yes, go ahead and make that larger. Perfect.
There we go. All right, we're going to talk about PrEP, HIV PrEP, which is pre-exposure prophylaxis and a very good way to prevent HIV in people at high risk, whether it's sexual risk or injection drug use risk. And we have a number of choices these days. We've got daily oral therapy. And I'm going to use the trade names here just because it's such a mouthful to say emtricitabine and tenofovir and tenofovir alafenamide. So you get Truvada or Descovy. And we have also a long-acting injectable, cabotegravir LA for long-acting, that is given every 2 months. But it's more than just the medication, right? That you really need to talk to patients about their sexual, I lost my screen here, about their, sexual behaviors, about what approach, oral or injectable, is going to work for them, and risk reduction in general. For example, if it's somebody who injects drugs, then harm reduction and syringe services are important. So Truvada has the broadest FDA certification. It's recommended for all persons at risk, regardless of what that risk is. The other two drugs, Descovy and Apretude is the trade name for cabotegravir, are more limited because they have not been studied in all populations. So Descovy is indicated for people at sexual risk, except for women who have receptive vaginal sex, which is a awkward and kind of bizarre exception, but they just didn't do any studies in heterosexual women. And cabotegravir or Apretude is also just recommended for individuals at sexual risk. And anyone can do this. This, unlike hepatitis C, which actually now the West Virginia Medicaid has gotten rid of as of June, gotten rid of the requirement for specialist oversight, but nonetheless, anybody who can write a prescription in West Virginia can prescribe PrEP. You don't need any specific background or specialization. And I think really people who are providing primary care are in a great position to be able to talk to their patients about their potential risk and to offer PrEP to people. So here's a algorithm for, there's two of these. One is, the first one's about sex, the second one's about drug use. So the standard approach to this is just to say to the patient, do you have sex with men, women, or both? And then you work your way through this algorithm depending on what kind of sex and whether the partner has HIV or the partner has an unknown status for HIV or whether they've had STIs. And if yes is the answer to these things, then this is a person who would benefit from PrEP. And if they say no to any of these, it's still worth discussing. And if they're interested, prescribing it to them. And the second risk behavior that you have to screen for is substance use disorder. So the question is, have you ever injected drugs? And then depending on whether you've done it or shared equipment, you would prescribe PrEP. I myself don't think it's an issue about whether it's within the past 6 months or even necessarily whether they've shared injection equipment, because people who inject drugs have sex too. So again, people who say no are certainly, it's not inappropriate to offer them PrEP. So is it safe? Well, to date, there's no reported serious short or medium-term safety concerns for the oral drugs. Truvada was FDA approved for PrEP back in 2012. So that's 10 years. And in fact, these oral drugs are not only considered safe, but you can use them in women who are pregnant and breastfeeding. All of the oral drugs have to be excreted by the kidney. So anything that decreases renal function could increase the serum concentrations of their component drugs, the TAF or the tenofovir or the FTC, the emtricitabine, and cause toxicity. And for cabotegravir, the most common side effect is really an injection site reaction. This is a 3 ml gluteal injection. So not a small amount, and really needs to be given by nursing personnel who are skilled in giving an injection that large. So there's a significant evidence base for the utility of PrEP, both sexual and injection drug use, although the least amount of work has been done in people who inject drugs. And in general, if you adhere to taking the medication as it is prescribed, then really you will do very well. Injection drug use has somewhat less of an effectiveness estimate, and this is because there was only one study, and actually that study here in the next, it's not there, but that study used only tenofovir, did not use a combination, and was done in Thailand. So you have to decide whether you think that gives you enough guidance for doing that here in a US-based population. You can achieve a protective plasma level if you take at least 4 doses of oral PrEP a week. So, if you're prescribing it for daily dosing, then, ideally you want people to take 7, but if they miss a couple, they'll still be well protected. What you do need to know and to share with your patients is that it takes longer to build tissue levels that are appropriate for the potential source of HIV to people. So if you have a patient who's having receptive anal sex, then after about 7 days of daily use, there will be appropriate tissue levels. But for heterosexual women and people who inject drugs, really it takes about 3 weeks of daily use to achieve, for example, appropriate levels in the female genital tract. So what do you have to do to work up somebody for PrEP? Well, you need to make sure that they don't already have HIV, because all of the medications for PrEP are only part of a full treatment regimen for HIV. And if you gave somebody part of a regimen, they already had HIV, they would very likely develop resistance. So you do routine testing. You should do the blood-based test rather than the oral rapid tests, which are less sensitive. And almost every lab now is doing the 4th generation test, the combined antigen antibody test, which is our most sensitive test for HIV. It's a good thing to ask people whether they've had symptoms that are consistent with a mono-like syndrome, or whether they think they may have been exposed to HIV recently, because there is a window period, even though it's brief for the 4th generation test, maybe 10, 11, 12 days, but there is a window period, and you certainly don't want to start somebody if they really have HIV. And then the only other routine assessments are for oral PrEP, renal function. You need to ensure that people have an eGFR of at least 60 for the tenofovir containing regimens, and at least 30 for the tenofovir alafenamide containing regimen. There's some link of cabotegravir to hepatotoxicity. So if that's what you're considering, you might want to check baseline LFTs. And you also need to know what your patient's hepatitis B status is, because the oral drugs that we use for PrEP are also drugs that we use to treat hepatitis B. And if you prescribe PrEP, oral PrEP for somebody who's got chronic B, and then they decide to stop taking PrEP, well, they could have a flare of their hepatitis B, which is not a good thing. But it's not a contraindication. If you have chronic hepatitis B, it's not a contraindication to oral PrEP. You just need to ensure that the patient understands that if and when they stop PrEP, they could have a flare, and that they need to be monitored for that. And then this slide tells you sort of what to do at routine intervals. I actually chaired the FDA hearing for Truvada in 2012. And I want to tell you that this idea of how many months you do everything was based on what seemed logical and what we thought was reasonable for patients to do. The studies were all based on monthly assessments, and nobody thought that bringing everybody in on a monthly basis was really going to work. So we settled on quarterly. So, and because you really want to ensure that somebody comes back in and gets retested for HIV, you never want to give them a prescription that goes past 90 days. And most insurance, and certainly West Virginia Medicaid, covers PrEP, although you may need a PA depending on what your choices are. There are patient assistance programs that are listed on this slide, and on this last slide are a number of the URLs for a number of sources about more information about prescribing PrEP. So there's the most updated CDC guidelines, that's from 2021. And then there are company websites for Truvada, Descovy, and Apretude, and also the National Clinical Clinicians Consultation Center PrEP line can be useful. And I think that's it. And happy to take any questions.
Thank you so very much, Dr. Feinberg, and for the great resources at the end and charts. Really appreciate you taking the time to speak with us today and present. Does anybody have any questions or comments regarding PrEP?
Hi, Dr. Feinberg, it's Kaylee. Thank you so much. You did such a great job at explaining it in such a condensed manner. And I hope that everybody on this call starts prescribing PrEP if they haven't already, because we certainly need more uptake with it. I don't have any particular questions, but there's a few comments that I just wanted to make, just especially in the last year or so with this new cabotegravir or injectable option of PrEP. Just a few comments about that. I've personally had some logistical barriers with getting cabo injections for patients. So just kind of be aware, if someone is in your practice and wants to start on the injectable formulation, there is a little bit of a process. That's not something that's as easy to get started in short order. There's some significant paperwork through the manufacturer that you have to fill out, and then you can choose if the medicine's going to be delivered to your clinic for administration. There's some training protocols, whatnot. So it's a little bit of a time gap, for those patients, but it is a great tool if they're not wanting to take a daily medicine. Cost, I believe Medicaid does cover cabotegravir, but as far as private insurances, it's, I've had one patient, we've been trying to get started on injectable PrEP since May, and we're still pending all of the prior auth paperwork and appeals and all that. So the other comment I wanted to make about the injectable in particular is we don't have the data yet in terms of how long it takes to achieve adequate levels of protection after they start. So whereas Dr. Feinberg really made a really good point that with oral PrEP, it does take 7 days in men who have sex with men to achieve detectable levels of the drug and have that good protective, those protective levels. Females and injection drug use, it's closer to 3 weeks, but with cabotegravir, we just don't have the data as to how long after you start will you be truly protected. So that's still kind of pending as well. And then the other comment I wanted to make was really in terms of testing and follow-up. So once you've started someone on PrEP and you're monitoring them, every 3 months, you should be doing HIV testing. You should really be doing follow-up testing with the HIV screen, but also an HIV PCR, because there is some delayed seroconversion. If they've been on PrEP, or even if they've discontinued PrEP in the last 3 months or 12 months with cabotegravir, but 3 months with oral PrEP, and they want to restart, they can still have some lagging drug levels in their system to where they may have some delayed seroconversion if they were exposed to HIV in that interim period. So really, when you're doing follow-up testing, make sure you're checking HIV RNA levels and the screen as well.
Yeah, thank you for those comments, Kaylee. That's really helpful. And actually, that reminds me that the other important thing to know about cabotegravir is, because it can last, a single injection can last up to a year, of course, with waning levels over that time. If people stop taking it, then those levels are waning. If you don't come back every 2 months for the new injection and get the level back up, then that is a setting in which you certainly could, if people were exposed to HIV, could pick up HIV and could develop resistance. So another thing to be aware of and talk to your patients about is that if they're interested in cabotegravir, they should know that the ideal situation would be that if they decide to stop at any time, they should then start oral PrEP, to ensure that they're not, that they're not going to be vulnerable because of these waning levels of, of cabotegravir. And it is, it is for some people really critically important for them not to have to swallow a pill every day, right? So that is, that's certainly a group of individuals for whom cabotegravir might be a wonderful choice. But, it does also require that every 2 months you show up in a medical facility and get this injection. This isn't something you do at home yourself. So while you don't take a pill every day, you got to show up at your, wherever you get your care. So it's not exactly like it's hassle-free. And that's an important thing to recognize.
I'm
Thank you, everyone.
Yeah, I'm glad you pointed that out too, Dr. Feinberg. If somebody does decide to stop cabotegravir, it's just not for them anymore, they do still need to follow up with you quarterly for the next year after discontinuation, because of the fact that what Dr. Feinberg stated with those kind of lagging, that prolonged tail end of the cabo levels and that increased risk of HIV resistance. So just kind of let them know if they do decide to stop it, they're not scot-free. They still got to see you for at least another year and do regular HIV testing.
Great. Thank you so much. Thank you for the following discussion. That's excellent. We actually have our second case presenter here, so we can go ahead and do that real quick if that's okay. We still have time. Dr. Brubaker, how are you? You can, yeah.
Good, thanks. Yeah, just unmuted. And is there like a sheet with the data?
I will share. Yeah, I'll share the screen if you're ready.
Okay. Yeah, sorry, my 11:40 was roomed at 10 after 12. So should I just jump in?
Yeah, go ahead.
Okay, so I'm down in Green Bank. This will be my first time trying to treat someone for Hep C in our little rural practice here. And a 34-year-old guy came to me with the story of basically polysubstance use and had been in rehab about a year ago and said he was free of opiates and amphetamines ever since that hospitalization. Probably still uses alcohol, marijuana, and smokes. But in the course of his prior hospitalizations knew he was Hep C positive, and there were some old serologies that or a viral load demonstrated historically. Yeah, that's probably the main things. He has a couple other incidental issues, sleep. I think he has some dental problems. Let's see, the main thing and the crux of of my kind of question with his case, other than, if you can go back up to the meds, other than just sort of figuring out the logistics of prescribing it and getting it through Medicaid, his med list seemed to me kind of the pattern of got put on these things for symptoms in rehab and then not followed by actual psychiatry since then, as far as quetiapine, the Paxil, the trazodone. He sort of had all the psychiatric diagnoses, PTSD, bipolar, insomnia, all kind of on the list from that hospitalization. So I don't think he had really been reassessed since he was off of drugs on the psychiatric front. And the two, I think it's been a little while since I looked at it, but I think might be the quetiapine and prazosin perhaps that where I'd entered these into the like Liverpool Med interaction checker website, and those both kind of flagged as potential interactions. So to skip ahead or move on down, yeah, we've got I think we've got immunization series going for both Hep A and B. He's a little overweight. His labs, once we did what I understood to be basically the things required, didn't really have any signs of fibrosis or any sustained liver, kidney disease. I got repeat. Yeah, he's HIV negative. Both the old labs and the current show genotype 1A. And then his log was a little bit higher than whatever the previous one was, in the 6s. So based on this and kind of working through our pharmacy here in community care, I kind of gathered that Mavorite was an appropriate choice. But it sort of took me several weeks just to get that set up. And I was just sort of like, I guess, hesitating before pulling the trigger just with the potential drug interactions. I think one of the Medicaid forms had an explicit question that was like, what is his med list? Are there any things that interact based on the drug monograph? And looking at the Mavorite monograph, there were, I forget what, but I think a couple of classic kind of CYP interactors on there that were like stated contraindications, but given that these potential interactors weren't, I was pretty much planning to proceed with the Mavorite, but I was wondering if anybody had any kind of level of comfort level with how much to worry about the interactions for this or the other Hep C agents.
I see you unmuted. Judith, go ahead.
Those are substantial interactions, Dr. Brubaker. I would not use Mavorite in this patient. I would use Epclusa. I mean, you indicated you're not so certain about what his need for those medications is in terms of, what his psychiatric status is, but those are not drugs you can sort of stop and start overnight. And hepatitis C treatment is at most 3 months. So, I think to me, the better part of valor would be to give this gentleman Epclusa and then, meanwhile, set him up for an appropriate psychiatric reevaluation and have, and see what medications he really needs to continue or not. But, by the time you do that, you could have cured his Hep C with Epclusa. So that seems like the way to go to me. Rachel is our resident drug interaction expert. I'll let her opine.
Sure thing. So the main issue with the Mavorite is going to be the quetiapine, like you said. So the interaction with prazosin is going to be there with either Epclusa and Mavorite. It's really theoretical, and I can tell you we've had patients that have taken those combinations together and tolerated it just fine, not had any major changes overall or adverse effects from having concentrations increase. So I'm less worried about that one. The only issue with the quetiapine is going to be the risk with Mavorite, where it would increase the quetiapine levels. So you're looking at the concerns with what you would with quetiapine toxicity. Primarily from a concerning standpoint is going to be the potential for like QT prolongation. So not sure if the patient has any history of any arrhythmias or cardiac abnormalities where you would be concerned about QT prolongation. We have given quetiapine and Mavorite together. A lot of it, I can't remember what Liverpool says, but they do have like a cutoff of recommendations. I think it's like 400 milligrams per day. So the folks that are doing like 300, we don't usually withhold the Mavorite for those. So if he is taking the higher dose, you could go and be more cautious and utilize the Epclusa, because that prazosin interaction I'm not concerned with at all from a clinical standpoint. And as far as checking that box with West Virginia Medicaid and their form is mostly just, if there's anything like really clinically relevant, you could say yes, and what your plan around that is, like if they're on a PPI and the Epclusa and how you're going to educate them to avoid that interaction. That's the main thing they're looking for. So stuff like this, if you're just worried like about the prazosin with the Epclusa, I would just recommend saying no, because clinically, I don't think that's going to have much of an impact for that patient.
Okay. All right. That's very helpful on both fronts. So that was what I was wondering.
Perfect.
Sorry about the delay with our clinic and me finally getting on here at the right time.
No worries. Hey, Quinn, it's John.
Hey,
So 1140 roomed at 1210. Are you sure you're not still at Ruby?
Yeah, that sounds about right, doesn't it?
But
Yeah.
the other thing, man, the second half of your question is like how to write the scripts and stuff like that. You write for a month at a time, which if it's Maverick, I can't do the math. I think it's 84 pills with 1 refill. And then if
Okay.
it's Epclusa, it's 28 and 2 refills. So you do 3 months worth of that one. And then do you want, I mean, my advice is anybody who's prescribing these medicines should use a specialty pharmacy. It's like having your own personal fairy godmother or godfather on your shoulder. That's how I view you, Rachel, a fairy godmother, Rachel. That's what I view you as.
That's right. That's a great way
That's
to
great.
describe it, John. Again, let's let Rachel say a word or two, but I'm totally in agreement. You and the patient will get terrific support from a specialty pharmacy. Rachel?
Well, I'd like for all of you to talk to my boss about my pay. But no, the benefits from a specialty pharmacy standpoint is that they can complete the prior authorization on your behalf, those of them that do it. So we do that here. And there is a specialty pharmacy in Charleston, Med Center Specialty Pharmacy. They are owned by Biomatrix, so they're not associated with a health system, but still they do offer prior authorization services. The main thing is just the coordination where if you do want the pharmacy to do the authorization piece, they just need you to send the clinical information. And the technicians and insurance specialists that do those, they are very familiar with the insurances that will they'll know exactly what's required, what labs they need, how soon they need them. So like West Virginia Medicaid needing labs within 6 months. I think on your sheet here it says September, so those are good to go. So they can help kind of coordinate that. If there's any additional information that the insurance would want, they can communicate that to you. And then kind of once it's approved, make sure that it's affordable. West Virginia Medicaid is $3 or less copays, so not usually an issue for the Medicaid patients. But after that, the pharmacist provide education to the patient and follow up with them, make sure they're not having side effects and that they feel comfortable with it, kind of assessing adherence and getting those plans together. So that's the quick and dirty version of the services and things that the specialty pharmacies can offer as an additional assistance that sometimes the community pharmacies are not able to do, because they don't have time. They've got a lot of retail set up a little bit differently than specialty, so they don't always offer those additional services.
So Rachel, how would he use you guys? He would just send a prescript to Allied or something?
Is that what it is? Oh,
Yeah, it would be Allied Health Solutions is ours up here. So you just send the script, and if there's anything that we need from we would reach out to you and say like, well, these are the labs that we need. If there's any forms for West Virginia Medicaid, you do have to sign that patient consent form and have the patient sign that as well, which we can always help coordinate. So anything that we would need, just so long as there's a good phone number on the prescription. And if you send an e-script, that would be if it comes via SureScript, we'll have that information on there. So if we need to reach out to you from our pharmacy, it would be Mary, Samantha, or Krupa that are here that are doing the Hep C auth. They would just reach out and say, hey, we got your script. This is what we need to do the auth. If there's anything you need to sign, they'll fax it to you and just need to fax it back. So the prescription is really how that process starts.
Okay. And Allied, that's in Morgantown. I'm pretty sure I remember that from.
Yeah, it should come up and say 3040
Option in
University
Epic.
Avenue.
Okay. Good.
It's worth doing, man. Then they'll even like tell you when you're supposed to check your SVR and stuff like that. If you're a forgetful fella like me.
Reminders of things. Yeah.
Yeah,
Awesome.
that one of us pharmacists will harass you for that.
Am I correct in thinking it's part of the program to get another viral load mid course, and then was the SVR is what, a couple months late out post treatment?
Yeah, man, 12 weeks out, SPR 12. You don't have to get another one, but you can if you want to assess adherence. If you want to make sure they're taking it. Sometimes patients like to feel good, and see that the viral load is dropped, number one. Number two, that the liver enzymes have normalized, although I think your patients already have normal liver enzymes. But there's a only really hindsight utility to checking a viral load halfway through. And it's sort of like if you didn't achieve SVR, you wish you had. checked it halfway through to see if they were even taking the pill. So at least
Gotcha.
that's my opinion on it. You don't have to do it, but feel free. But
Yeah.
then remember, you gotta fill out a consent form for Medicaid too, by the way. You got that from their website.
Got that agreement that like.
Yep.
Provider. Yeah, we've been like digging into all this stuff, and I've seen the guy actually a couple times on the like his arthritis and tooth issues. He keeps finding his way back, and might follow up better than I might have initially expected just to look at him. So I'm kind of hopeful for him seeing it through. But yeah, I placed one of our internal psychiatry referrals the first time I saw him, and he hasn't gotten in with that yet. So I was hoping the other polypharmacy stuff would have been sort of rationalized by the time I finally got around to starting the Hep C treatment, but it just didn't play out that way.
Well, proud of you for tackling it, man. This is your first of many.
Yep. Yeah, I hope so. Now that there's plenty of folks down here where it's just instantly on their med list. They said, no, I didn't know I could get that treated. So hopefully we had looked through the prior auth stuff, the actual paper, the Medicaid stuff for this guy. I was looking through it with my nurse. So trying to educate all of us as just to what the hoops are for our overall kind of fluency.
Excellent. Thank you so very much. Really appreciate it, and glad you could make it. Do you have any further questions?
No, that was probably the highlights
All
of
right,
it.
and we'll get that case back to you with the post recommendations as well. All right, does anybody have any following comments or questions for the session today before we do our closing remarks? All right, well, with that said, our next session is actually canceled because of the holiday for Thanksgiving. So I hope everyone has a great holiday with friends and family, and we will look forward to seeing you guys again soon. We'll send those updates in email. All right, thank you so much.
Bye.
Bye.